The following set of slides relate to psychological aspects of care. This refers to step 1 competencies for nurses of promoting a positive patient experience. These step 1 competencies are broken down into the 5 following elements. Number 1, being able to understand the concept of holistic care and how it can be incorporated into your practice. Number 2, know the common feelings experienced by patients waking up in critical care. Number 3, understand what impacts on the psychological well-being of critical care patients. Number 4, understanding the importance of developing trust, communication, and individualized care plans. And finally, 5, assisting patients to regain control, be involved and empowered, and enabling acceptance and grieving. Part 1, holistic care in the ICU. So, what is holistic care? Sometimes referred to as biopsychosocial care. It's the care of both the psychological and emotional well-being of the patients and their families or carers and loved ones. It includes the impact of the sense of self, an adaptation to illness and its consequences, communication, spiritual care, social functioning, and relationship. In essence, it's the whole person. It's holistic in its approach and it's different to that medical model. Nursing practice of psychosocial care is focused more on the patient and less on the disease or injury process. Part 2. What are the common feelings experienced by an ICU patient when waking up in critical care? Common feelings experienced by ICU patients on waking up in critical care include feelings of dehumanization. The patient does not feel like themselves. They may express feeling disconnected from their bodies. Feelings of a loss of reality. This is commonly associated with delirium or the aftermath of delirium. Feelings of a loss of sense of self or a loss of worth. The limitations upon the patient alongside physical aspects and the impacts of delirium may lead a patient to experience their loss of self-esteem or a sense of their own self and related meaning and purpose. A loss of control and choice. The patient will experience low-level control over their environment and additionally over their body. Given that their memory of this is prior to admission, it's likely to be different. The patient is likely to be distressed by this contrast. This may impact their engagement in physical activities. Patients will also feel a loss of time due to the impacts of sedation, and they may experience a loss of hope. All of these changes lead to potential psychological distress, including fear, worries, impact on mood, feeling confused, and potentially withdrawing or going quiet to cope. It is important in the early days post-sedation in ICU that we avoid the use of mental health labels and diagnostic criteria to explain our patient's reaction. For example, staff may often refer to the patient as being traumatized or having PTSD. In reality, a diagnosis of PTSD requires 4 weeks of sustained avoidance, re-experiencing, and hyperarousal. It is better to describe the patient's experience as what's known as an acute stress response. The patient needs normalizing and a chance to talk through, discuss, or process what they've seen. This may take time, and this may not fully happen during their time in ICU. Another common misdiagnosis is depression, when it's more likely that actually a patient is fed up, confused, or withdrawing to cope. For a diagnosis, we need at least 2 weeks worth of a combination of symptoms of lack of enjoyment, lack of self-worth, poor sleep, poor motivation, and a low sense of hope. What the patient needs is information to balance their hopes, to feel encouraged, and activity particularly enables mood. Another misdiagnosis is to use the term anxiety. Anxiety is diagnosed when the fear is disproportionate to the situation and it impacts on a person's functioning, potentially leading to avoidance, where it's more likely that the patient is reasonably worried and fearful in the difficult ICU environment. Patients that appear worried need reassurance, encouragement, and also sleep so that they can think through and problem solve effectively. It is important that we assess the patient needs, and there's a screening tool that doesn't take long that we can use that's been validated for use in intensive care. It's called the Intensive Care Psychological Assessment Tool, or IPAT for short. We ask the patient yes/no questions and differentiate between yes a little bit, i.e. 1 or 2 times, or yes a lot, almost every day. We ask them the following 10 questions. Has it been hard to communicate? Has it been difficult to sleep? Have you been feeling tense? Have you been feeling sad? Have you been feeling panicky? Have you been feeling hopeless? Have you felt disorientated? Have you had hallucinations or seen or heard things that you suspected were not really there? Have you felt that people were deliberately trying to harm or hurt you? And do upsetting memories of intensive care keep coming into your mind? This IPAT tool enables a referral to psychology within critical care. It also allows us to monitor a patient's progress. Part 3. Let's now break down what impacts on the psychological well-being of critical care patients. As an ICU nurse, you may become desensitized or learn to tune out the noises and lights and people within an ICU environment. However, for the patient, this will be typically their first and only experience of ICU, and they're likely to be physically and cognitively deprived in their resources to manage the stimulation in ICU. So one of the key distressing factors of ICU is sensory overload. It's the environment themselves. Beware of offering earplugs or eye masks, because sometimes this may impact on a patient's ability to voluntarily remove them, and therefore making it a deprivation of liberty. So it needs to be a choice, and the patient needs to be able to remove them. Following on from sensory overload, the patient is unlikely to get to sleep and have a poor sleep-wake cycle in the first few days following withdrawing from sedation. So we should try and stimulate during the day and keep sleep for nighttime where possible. Avoid excessive daytime napping where you can, especially in longer-term patients. Patients may be experiencing pain. It's possible that actually this can increase their distress. So be careful of pain and make sure it's adequately assessed and managed. Confusion and disorientation are common elements in the early hours and days post-desedation. They can be temporary, or they may be indicative of delirium. See our delirium teaching in another video. Another aspect of that delirium is hallucinations and delusions, which affect patients' relationship with the environment. All of these can lead to a fear or stress response.